Please help me welcome our third speaker, Professor Ricardo Diaz. He's an infectious disease specialist who conducts translational HIV research at the Federal University of Sao Paulo in the Department of Infectious Diseases. He comes to us with a wealth of experience and is well published in his areas of interest, which include HIV genetic diversity and its relationship with pathogenesis, HIV antiretroviral resistance, and cure research. He'll be giving us our third talk, which is titled Dual Regimens, What are the Resistance Considerations? Welcome.
Thank you very much. Let me see. Yeah, but the pointer? Oh, right. Okay, just testing. Thank you. So I'm going to talk about resistance. This is my disclosure, and I have also another disclosure. Every time that I express my own opinion, I will show this this picture of this guy. This is my wild guess, and of course, some people cannot agree with this. So right before I start to talk about resistance, I just want to contextualize about the 3TC with a higher genetic barrier second drug, second class, like dolutegravir or boosted PI. And why is that? Of course, because we have some problems with the other nucleosides. It's interesting because some of those problems are related to the host. We have genes that can predict any of those troubles. So if you have a precision medicine in the future, maybe we can mitigate all those troubles, but so far you can look and see that the 3TC is not in that list. So that's why we use 3TC. Why we use dolutegravir? Well, just because we have more tolerance and less toxicity compared to boosted PIs. And to my mind, another important question is it dissimilar to use 3TC plus dolutegravir than two other nucleosides plus dolutegravir? So I have some questions in my mind, and I think that those questions have been answered. The first one is the potency similar between 3TC and dolutegravir plus the two nucleosides and dolutegravir? We can see the potency of a regimen by the decay of the viral load. And this has been done. And published. So those are not head-to-head studies, but we can see by the ACTG A5353 and other pivotal studies that the decay is the same when you use two nucleosides or only 3TC. It doesn't matter if the viral load is higher than 100,000 copies. So that's solved. The other question is the performance similar between those two regimens? It's different than the potency. I'm talking about the time that it takes for a viral load below detection limits. And we can see that the performance, the clinical performance, is the same by the Gemini study. So it's the number of people with viral load below detection limits is the same. The other question is about the efficacy of the virologic suppression. Is this similar? So we can see that the time to get the viral load below detection limit is absolutely equal between those two regimens. So there is a final question, which is the genetic barrier to resistance adequate when we have just a true drug regimen? First, let's define the genetic barrier. The genetic barrier is the distance for the acquisition of complete resistance. So it's a matter of how close we are to the resistance. It doesn't relate really to the number of the mutations, but in how close we are to get the resistance. And what we have is that only two patients, got resistance using 3TC and dolutegravir. One patient from the Gemini study, 1 out of 716, and another patient for the ACTG 5353, it's 1 out of 120, and those are the case. In the top of the slide, we can see the Gemini study, and one participant in the 3TC dolutegravir arm evolved with M184V mutation at week 132. The viral load was 61,000 copies. Then there was a selection of the dolutegravir mutation at codon 263, a mutation that appears mainly in subtype B HIV. And that was in week 144. And the viral load was 135 at that point. The other patient from the ACTG 5353 also selected first 184V mutation, the 3TC FTC mutation, at week 8, and the viral load was 6,000 copies. Then, again, it's similar. There was a decay in the viral load and the emergence of the 263 mutation at week 24. Interestingly, they performed the phenotype assay, the direct measure of resistance, and this 263 mutation was not related to a great deal of resistance. The fold change is the phenotypic mark of resistance. The higher the fold change, the higher the resistance. Sensitivity means fold change of 1. And you can see here that it looks like that there is no resistance. But my opinion is this assay could be not good enough to detect resistance. And I'll explain why. So far, and that's my opinion, the genotypic correlates of resistance to integrase inhibitors are not completely elucidated. You know what? The integrase inhibitors acts inhibiting at least 3 stages of HIV replication. In the first round of replication, it's preventing the integration. Then it's also preventing the assembly of the virus. And after that, it goes to the particle, and in another cycle of replication, it can inhibit the reverse transcriptase. It's like a 3-in-1. So this is our work in Lescroix, showing that when you are going to talk about assembly of the virus, the maturation of the virus, the dolutegravir can bind in the NEF region. It's a 3-ppt portion of the NEF region, and we know that some mutations there can show that there is a resistance to dolutegravir. And we just evaluate 51 samples from patients failing dolutegravir, and 6 of them had that mutation. By the way, that was the poster that was more viewed in the Lescroix. And we also show that only one of those patients to the right have the mutation to dolutegravir at the integrase region. So we are not looking to the entire genome. That's why the correlates are not that clear. And when we do the phenotype assay, what we can say is that we are not including that part of the genome to see if there is resistance. What about transmitted drug resistance? If you have a 3TC resistance, for instance, is this going to impair the initial treatment? Well, we look at 3TC resistance to the M184V mutation, and also, I don't think this is fair, because there are other mutations that cause 3TC resistance, such as the TAMS mutations, those 6 mutations that are selected by zidovudine, or the K65R, that's the tenofovir mutation. So when we design studies to include resistant strains, we look mainly to 184V, and we should look at the other mutations. 184V, it's a very common mutation for secondary selected resistance, but it's rare for transmitted resistance. That's why you cannot include many patients in those studies. And what I can say is also that maybe those mutations will not impair much the 3TC dolutegravir performance. And we have these insights from studies that show us that the function monotherapy is going to work. Function monotherapy is when you have resistance and you are using that drug. I don't like this term because there is no such a thing as functional monotherapy, because in some drugs you have the residual activity, such as the nucleoside. But let's talk about this residual activity, and we have the insight from the NADIA study. The NADIA study just got patients that were failing efavirenz or nevirapine with tenofovir and 3TC or FTC. And many of those patients have resistance to tenofovir and to 3TC. So the design was, first, they randomized the patients to do the salvage therapy using either the dolutegravir or darunavir. Then a second randomization for 3TC and tenofovir or 3TC and zidovudine. But I want to show it's in their error. For many patients, we don't have any nucleosides that were fully active, 0. And look at the performance, 91% in the dolutegravir arm and 92% in the darunavir arm of viral load below detection limits. This is like a start of a treatment. And so if you have a very good drug with a high genetic barrier, such as dolutegravir or darunavir, and potent, we don't need much. 2 nucleosides that have resistance will work. So that could be the white guess. It's interesting to note that if you have fully active nucleosides, more than 2, as in the bottom, this is not going to work well. Because if you have sensitivity, it's because you have bad adherence. We saw this in other studies. So if you are not adherent to a first-line treatment and don't select the mutations, you probably will not adhere to the next regimen. But we can see that partial activity of nucleosides is going to be enough. And what about resistance to dolutegravir? We can say about some polymorphic mutations or some transmitted resistance. And some insights came from studies that look at what we call target not detected in the viral load. It's like that. When you have a viral load assay, the dynamic range of detection is going from 17 copies to 10 million copies. But below 40, you cannot really quantify. So, meaning that 17 may be the same as 39 copies. So what we do is, you have a result with viral load below detection limits, meaning that is 0, I can't see virus in that sample, or less than 40 copies, meaning that there is a virus there, but I'm not quantifying. So look at this study. They got all the patients in the bictegravir, the TAF and FTC, and look at the patients that have the target not detected, which is viral load below detection limits. And they look at the correlates of target not detected. And it makes sense. If you have the higher viral load, more than 100,000 copies, you see virus there. If you have low CD4, less than 200 copies, you see virus there. And if you have a lower adherence, lower than 95%, you also see virus there. I don't like 95%. This is outdated. The Quatur study showed us that if you take drugs 4 times a week, it's the same as taking every day. So the cutoff for adherence changed. Anyway, it's 95% here. And if you look at the multivariate analysis, it's like the higher viral load to see the virus, the lower CD4 to see the virus, symptomatic HIV, and mutations at the integrase gene. Those are secondary mutations, showing that maybe those polymorphic or transmitted mutations can make the difference to the perfect viral load below detection limits. And how frequent could be integrase mutations? Should I care about that? Well, we need to look for it. And I invite you to see our poster number 18, about transmitted drug resistance in Brazil. And is it the same to start the treatment with some resistance or make the switch, what I call de-escalating a stable treatment? You are reducing the potency when you do the switch from 3 drugs to 2 drugs. And this is important because when you are doing that, you have an immunity in the host that's much stronger. And you know that the immunity is important to help to control viremia. We learned that in the monkey studies. So I can say that de-escalating a stable treatment may be less risky. Look at this. This is one monkey that was treated with tenofovir, FTC, raltegravir, and darunavir. And the red line is the viral load. It dropped to below limits of detection, and also the CD8, the immunity, was rising. Then they knock out the CD8. They gave antibodies and CD8 and brought the CD8 to 0. And look, the viral load starts to appear. This is the red line after the knockout of the CD8. And the viral load was just below detection limit again when the CD8 start to come back. So immunity is important. And we know that when people are not being treated, they have a repertoire of CD4 that's composed by the memory T CD4, which doesn't help much. But when you treat the patients, we are going to replace the memory T CD4 by the naive T CD4. And this is going to help the immune system. And how long it takes? 6 months. So that's why the switch studies wait 6 months to make the switch, because you have a stronger immunity. So let's talk again about the target not detected. The SALSA study was also a switch study from patients with stable viral load below detection limits that were randomized to switch to 3TC plus dolutegravir, or keep the 3 drugs. And they looked if those resistance mutations that were at the baseline, looking at the DNA. So you do the genotype at the DNA, and you find resistance sometimes. Is this going to change the below detection limit, the target not detected, like that bictegravir study? So the answer is no. You can see here that the chance of having target not detect was overall 81% in the dolutegravir 3TC arm compared to 83% in the 3 drug arms. And if you have mutations, sometimes you do have mutations, it's the same. You can have any TAMS, M184V, the 62 mutation that comes from the 151 complex at the NRTI related resistance. NNRTI resistance also doesn't matter, major PI resistance, and look at the right. You may have also some integrase resistance mutations, maybe some major mutations. This can be transmitted. This can emerge over time. You can discuss this, even with viral load below detection limits, but it doesn't matter. Once you did the switch in those patients, this is not going to impair the performance of the 3TC dolutegravir double therapy. So just as a final consideration, taking 2 drugs should be less toxic and more tolerable than 3 in a given regimen. That's why we think about this strategy. Of course, we cannot use 2 drugs with first-generation integrase inhibitors such as valtegravir or elvitegravir. We cannot use this with non-nucleosides. We cannot use this with unboosted PIs because they don't have the potency and the genetic barrier for a true drug regimen. And we learned this, for instance, in the switch mark study. And it's all about the risk. So what's the risk of having low viremia? If you have low viremia, you may have inflammation. So far, no risk. I didn't show the data, but the inflammation is the same in the 3TC dolutegravir compared to 2 nucleosides and dolutegravir. Is there any risk of virologic failure? No, it's the same. Look at the Gemini study. And resistance upon failure, well, it's rare. I showed you 2 cases. And what about the number of drugs in a given regimen? So we'd like to have 1 drug, like we have penicillin for syphilis. We don't, but we may. So far, we do not have 1, but we have 2. And most of the times, we will not need 3. We will need for salvage therapy, hepatitis B, other conditions, but 2 is being so far a good way out for the treatment of HIV patients. Thank you for your attention.